Welcome to Deep Dive Ortho, the show that, well, really tries to cut through the noise and bring you the insights that matter for your practice.
Glad to be here.
Today, we're tackling something huge, something that affects almost everything we do, professionally and personally. It's this idea of the post-truth era.
Mm-hmm.
It properly landed in the public mind when the Oxford English Dictionary made it Word of the Year back in 2016.
Feels like longer ago almost.
Doesn't it? And then you had things like Michael Gove's rather provocative statement that the country had had enough of experts.
Right. Aimed at politics, of course.
Exactly, but the ripples spread much wider, didn't they?
Yeah.
Right into medicine, into our world.
Absolutely. You can't separate these broader cultural shifts from what happens in the clinic.
So that's our mission for this deep dive.
Mm.
How does this cultural shift, this different way people approach facts and expertise, how does it specifically hit orthopedic care?
And what can we do about it?
Precisely. How do we, as orthopedic professionals, hold onto our position as trusted experts, adapt to what patients expect now, and, crucially, keep delivering excellent care in this? Well, information-rich, sometimes misinformation-rich, landscape.
It's a complex challenge.
It really is. And joining me to help us navigate it all is the very insightful Prof. Mo Imam.
Thank you. It's great to be talking about this. It feels incredibly relevant, doesn't it? More now than ever, perhaps.
Absolutely. Couldn't agree more. #Turd1. The enduring and evolving nature of trust in orthopedics. So let's dive right in. Where better to start than trying to define what this post-truth landscape actually looks like, on the ground?
In an orthopedic setting.
Okay.
When we say it's an environment where feelings, personal beliefs, sometimes seem to carry more weight than objective facts,
Right.
how does that actually show up in our clinics, in our conversations with patients?
Well, it's quite tangible, actually. It's not just theoretical. You see it reflected directly from those broader societal shifts right there in the consultation room.
We live in an age where information, and crucially misinformation, is everywhere, instantly accessible. So patients don't just walk in with, say, a sore knee.
No, they come armed.
Exactly. They often arrive with quite firmly held opinions, maybe shaped by a forum they read online or a story a friend told them or, something trending on social media.
Not necessarily based on solid evidence.
Often not. And that's the crux of it. We can't just assume anymore that our evidence-based advice will land just because we're the experts.
Mm-hmm.
A diagnosis, a treatment plan, something we know is backed by solid research, might suddenly be met with real skepticism. Why? Because it doesn't quite fit the story the patient already has in their head or their gut feeling about it.
The job changes.
Fundamentally, it becomes less about just giving facts and more about navigating a conversation where personal beliefs are already quite dug in, where objective reality might feel, well, less real to the patient than their own truth.
It's a dialogue then, a different kind of dialogue.
Precisely.
Yeah.
And trust, persuasion, they're earned differently now.
That's a really interesting way to put it, moving from dispensing facts to navigating narratives, which brings us straight to that unique dual role we have as orthopedic surgeons, doesn't it?
It does.
On one side, we're the expert, the specialist. On the other, we're the patient's advocate. So when a patient comes in with a really strong belief, maybe from Dr. Google, how do you handle that tension? Balancing their autonomy, their right to choose with our fundamental duty. First, do no harm.
Yes. That's the absolute heart of the dilemma, isn't it? It's where our professional responsibility really gets tested.
Definitely.
As surgeons, we're in this unique ethical spot. We're guardians of very specialized skills, deep knowledge base built over years. Patient autonomy is, of course, vital. Shared decision-making is key.
But it can't override everything.
Exactly. It
Right.
can't, and it shouldn't override our commitment to doing good beneficence and avoiding harm, non-maleficence. What's really striking is that, unlike, say, a political issue that you could have a referendum on,
Right.
no amount of patient desire, no public vote can force a surgeon to do something they judge to be, well, a foolhardy total joint replacement, or just medically wrong.
Our judgment still counts.
It has to.
Yeah.
Our role as advocates means championing what we genuinely believe is best for that patient, even if that means we have to gently but firmly push back against what they initially want.
Which can cause friction.
Absolutely.
Mm.
Especially now, patients feel empowered by all the information or misinformation online. They might ask for things that just aren't backed by evidence or carry risks they haven't grasped.
So advocacy sometimes means saying no?
Sometimes it does,
Yeah.
or guiding them towards safer, proven options. It's not about just ticking boxes on their request list. It's a very fine line, but absolutely crucial.
That distinction is so important, grounding what we do in expertise and ethics, even with all these shifts. And despite these tricky bits, doctors, medical professionals generally, still seem to command incredibly high public trust.
Yes, remarkably so.
That recent poll you mentioned, 92% trust rating, and has actually gone up recently. What does that figure really tell us about where we stand, especially compared to other professions? It feels like gold dust.
It is gold dust, our most prized asset, no question. And it's a huge testament to how the public still sees the medical profession.
It's quite something.
To see 92% trust, and for it to rise in an era where trust in pretty much everything else is, well, falling. It's extraordinary.
Mm-hmm.
It shows that despite the info overload, despite the post-truth noise, there's still this fundamental belief in our integrity, our commitment to care, our expertise.
Unlike other fields.
Well, you contrast it with the steep decline seen in trust for professions like, say, the clergy over the same period. It really highlights how unique our standing is.
And that trust helps.
Massively. It gives us a critical advantage, a foundation, especially when we need to navigate difficult issues, push for best practice, or deliver tough news. It's a bedrock of credibility few others have.
But we can't take it for granted.
Absolutely not. It's not an entitlement. It's earned every single day through consistent dedication, ethical practice, basing what we do on evidence. We have to consciously work to keep it.
It's certainly a strong position, but also a big responsibility. Yet, even with this high trust, we're not immune, are we? Scrutiny happens.
No, not at all.
Think about those narratives that pop up like, greedy junior doctors or GPs ignorant of rules on billing, or the really serious stuff like the concerns over metal-on-metal implants that led to recalls. How do things like that challenge the trust we've built?
They're incredibly damaging,
Yeah.
precisely because they chip away at that core asset, public trust.
How does that work?
Well, they often tap into existing anxieties, maybe frustrations with the system, sometimes just a general anti-establishment feeling.
Right.
When you hear phrases like greedy junior doctors, even if it's not representative, it immediately plants a seed of doubt. It suggests maybe it's not all about patient care, maybe money's a factor.
Undermining the altruism.
Exactly. And similarly, stories about billing issues or the very real problems with some metal-on-metal implants. Those big recalls were significant. They sow doubt about our competence, our judgment, maybe even our ethics.
And it can twist how people see expertise itself. The outline mentioned expertise becoming a foe.
Yes, that's the real danger. Expertise, which should be our strength, our core value, can get subtly reframed, spun negatively.
How so?
Instead of seeing dedicated experts providing vital care, the narrative can shift. Suddenly we might look detached, maybe self-interested or fallible in ways that just erode our authority.
So vigilance is key.
Constant vigilance.
Yeah.
And proactive engagement. We need to make sure our story isn't just told through isolated incidents or sensational headlines. Public perception is fluid. That trust isn't guaranteed forever. We keep earning it. #tag2. Embracing evidence and overcoming internal obstacles to best practice.
And that vigilance needs to be internal too, right? Within the profession itself.
Absolutely. Critically so.
One of the things mentioned is that classic internal challenge. The in my hands argument. You hear it a lot. People use it to push back against studies, even really good quality research.
Yes, the in my hands defense.
Yeah, it's powerful.
Why is that resistance to evidence, that reliance on personal anecdote over solid data, why can that be so bad for actually moving orthopedic practice forward?
It's a really significant internal barrier. And look, it comes from a very natural human place, valuing your own direct experience.
Sure. Surgeons are hands-on people.
Exactly. Tactile, practical. There's this deep-seated, understandable belief that your own clinical experience, your own patient outcomes are the ultimate test. You see it, you feel it, you believe it.
But experience isn't everything.
Well, personal experience is invaluable for skill development, for intuition, for refining technique, no question. But when it's used as a shield, a way to dismiss any study, regardless of quality, then it becomes a problem, a barrier to progress.
Oh, so. It stops us improving collectively. If we routinely dismiss solid, peer-reviewed evidence, maybe a big multi-center trial, just because my patients always do well this way or I've done it like this for 20 years, we risk sticking with practices that might actually be suboptimal, maybe even harmful compared to newer, proven approaches.
So patients miss out.
Potentially.
Yes.
Imagine a new technique, backed by strong evidence, shows fewer complications or better long-term results for a certain fracture. If a surgeon ignores that because of their in my hands view, their patients don't get that benefit.
Holds the whole field back.
It hampers our agility or responsiveness to new knowledge. Ultimately, it's a disservice to patients who deserve care based on the best, broadest data available, not just one person's comfort zone.
So embracing evidence even when it's uncomfortable.
It's fundamental,
Yeah.
a cornerstone of ethical practice. It drives innovation. It improves outcomes for everyone.
So it's about integrating experience with the evidence, not using it against it.
Precisely.
Yeah.
Thoughtfully.
And speaking of evidence, there's often that debate about different study types. Pragmatic studies reflecting the real world versus those tightly controlled randomized trials.
Yes, the RCT versus real-world effectiveness debate.
How do we make sure we're properly appraising all this evidence without just falling back on those simplistic analogies? Dismissing things as apples and oranges. We hear that far too often.
We do.
Ew.
And getting the nuance right in appraisal is absolutely key. It's definitely not a binary apples and oranges choice.
Good.
Each study design has a different vital role. They offer distinct insights. RCTs, for example, give you brilliant internal validity, strong evidence for cause and effect, but under ideal, often quite controlled conditions.
Which might not reflect my typical patient list.
Exactly. The strict inclusion-exclusion criteria needed for rigor can sometimes limit how well the results apply to the diverse, complex patients we see every day.
And pragmatic studies.
They're designed specifically to mirror real-world practice more closely. Broader patient groups, fewer rigid rules, outcomes that matter in routine care. They might have more variability, sure, but they offer invaluable insights into effectiveness in normal settings.
So it's about understanding the pros and cons of each.
It's about sophisticated interpretation, understanding the strengths and the limitations of each type, not just rejecting one because it isn't the other.
I'm just moving beyond fruit analogies.
Way beyond. We need robust appraisal frameworks that consider the research question, the methods used, the relevance to our clinical context. It takes intellectual humility, embracing complexity, constantly learning not just what did they find, but how did they find it and why did they design it that way?
Intellectual humility. I like that. It feels crucial here, and it connects directly to another pitfall, cognitive dissonance.
Ah, yes. A powerful force.
The text describes it as those mental acrobatics we do to make evidence fit our existing beliefs. The example given was quite stark. Painful non-union after using a dynamic hip screw for a specific unstable femoral neck fracture, even when studies like Rangel's suggest another approach might be better.
It's a classic, unfortunately common example.
Can you elaborate on how that dissonance, that discomfort with conflicting information, really gets in the way of adopting better methods?
Cognitive dissonance is incredibly powerful psychologically, and it's particularly sneaky in medicine. Essentially, it's that deep discomfort we feel when our beliefs, our actions, or preferred ways of doing things clash with new, strong, objective evidence.
And we try to resolve that discomfort.
Subconsciously, often. We tend to twist or downplay the new evidence so it fits our existing view, rather than doing the harder thing, changing our view to fit the evidence.
Like with the hip fracture example.
Exactly. You might see a solid study, like Rangel's 2015 paper, suggesting intramedullary nailing has better outcomes for certain unstable patterns. But the dissonance kicks in. Instead of integrating that, maybe changing a long practice technique.
You find reasons not to.
You find ways to discount it. Oh, their patients were different. My technique is better than the one they studied. It doesn't really apply to my patients. It's mental gymnastics to keep things comfortable.
And the impact.
It significantly slows down the uptake of genuinely better methods. It delays improved outcomes. It might mean we keep using less effective or even riskier approaches just to maintain our comfort zone.
So we need to challenge ourselves.
Actively question our biases. Practice self-reflection. Cultivate a genuine openness to being wrong, even when it feels, uncomfortable. It's humbling, isn't it? To think we might cling to something just because it's familiar.
It really is humbling, and that need for self-reflection ties into the ideal of getting it right first time. It's highlighted as a cornerstone.
Absolutely. A crucial goal.
But, as you've noted, orthopedics offers a heterogeneous set of interventions. Lots of different ways to do things. How do we square that circle? The ideal of consistency and perfection versus the reality of varied approaches and surgeon preferences.
That's a central tension. Getting it right first time, or GRFT, as the national initiative calls it, is the ideal we should strive for. GRFT reports highlight unwarranted variation, which is a real issue.
So variation isn't always good.
No. While some variation reflects the necessary art of medicine, dealing with unique, complex cases where evidence isn't clear-cut, Significant variation in how we treat similar problems, especially when it's not evidence-based, is problematic.
So how do we reconcile the ideal with the reality?
Strategically, we need to identify areas where evidence does clearly point to a superior approach, and then we work towards standardization in those areas.
So not eliminating all individuality?
Definitely not. It's not about turning surgeons into robots following flowcharts. It's about establishing clear, evidence-based pathways for common conditions, using national registries to track outcomes, identify outliers, fostering a culture where following evidence-based guidelines is the norm.
And the complex cases?
That's where the art, the individual clinical judgment, really comes into play when the evidence isn't definitive or the patient has very specific needs. The goal is reducing unwarranted variation, ensuring everyone gets high-standard evidence-based care where it exists, while preserving space for bespoke treatment when justified. #33. Balancing individual autonomy with evolving standards of care.
That's a really helpful distinction. Standardization where appropriate, bespoke care where needed. Now, historically, becoming a consultant meant independent practice, the autonomy to create really tailored treatment plans.
Yes, a long-standing tradition.
How is that tradition being challenged now by these calls for more universal and generic care? And how do we avoid becoming, as the text rather bluntly puts it, drones, just following flowcharts for BMI, cement bearings?
It's undeniable that the traditional model of consultant autonomy, where your seasoned judgment was the primary guide, is facing significant pressure.
From where?
Various places. The push for cost efficiency, the need for tight quality control, the drive to reduce that unwarranted variation we just discussed. It all points towards more universal approaches.
Manifesting as guidelines and protocols.
Exactly. More national guidelines, more registries tracking outcomes in minute detail, protocols dictating choices on BMI cutoffs, bone cement, bearing types, and arthroplasty. The list goes on.
And the worry is losing individuality.
The concern among experienced clinicians is real and understandable. Will we just become operatives, plugging data into flowcharts, applying generic solutions?
A loss of nuance.
Potentially. While standardization boosts safety, consistency, and manages costs, it can feel like it erodes nuanced judgment, that unique relationship with the patient. The art is applying general principles to specific individuals. The fear is over-reliance on generic pathways, depersonalizes care, reducing patients to data points.
That is a profound concern. So if the implant, the procedure becomes more standardized in many areas, as evidence suggests it should, where does our individuality, our expertise as surgeons, truly shine through? How do we stop this shift feeling like a devaluation of our personal contribution?
This is where we absolutely need to shift our focus, broaden our lens, move beyond just the implant of the technique, and concentrate on the overall care experience, holistically.
Okay.
While the implant choice or surgical method might become more evidence-driven, rightly standardized in many cases, our individuality and expertise shine brightly in the human connection. The patient-centered aspects,
Such as?
the artistry of the consultation, the empathetic listening, the nuanced communication, answering those critical personal questions that define the patient's experience. Was I really listened to? Did they judge me for being overweight? Did I trust that person across the desk? Am I actually happy with this plan?
The intangibles.
Precisely. Those intangible but utterly critical elements. Our expertise isn't only surgical dexterity, vital as it is, it's also our ability to empathize, explain complex things clearly, manage expectations realistically, guide someone through a potentially scary journey.
Things a flowchart can't do.
Exactly. These things can't be standardized or captured by an algorithm. They're intrinsic to us as doctors, as humans. That's where our unique contribution lies, where we can excel individually. It's that blend of science and human understanding that makes the real difference.
That's a really powerful way to think about it, focusing on the human touch, the connection. And the deep dive points out that while a surgical disaster, a catastrophic arthroplasty, is devastating.
Thankfully rare.
Right. But more patients will experience a deficit in the former outpatient experience than the latter. What does that tell us about how we should prioritize patient interactions, especially in outpatients, often just seen as the pathway to surgery?
That insight is incredibly important and honestly often overlooked in busy systems. A catastrophic surgical outcome is devastating, no doubt, for patient and surgeon. But thankfully, it's relatively rare in modern practice.
Whereas the outpatient experience
Is universal. Every single patient goes through it. The initial consult, follow-ups, the communication, the empathy they feel or don't feel.
So the cumulative impact is huge.
Far bigger. Thousands of okay-ish or poor outpatient experiences likely have a much greater negative impact on overall satisfaction, public trust, and perception of our profession than those rare surgical catastrophes.
So we need to prioritize it more.
Absolutely. Elevate its importance. It's a massive, often underused opportunity to build trust, make patients feel heard, valued, set the stage for a positive journey before they even see an operating theater.
It empowers them.
Hugely. Good outpatient interaction reduces anxiety, builds partnership. A poor one, feeling rushed, unheard, judged, erodes trust rapidly, coloring everything, even if the surgery itself is technically perfect.
It's often the first and main contact point.
Exactly. Critical for defining the quality of care we provide. We have to remember that. #tag4. The thorny issue of rationing and access in orthopedics.
That really drives home the importance of every interaction. Okay, let's shift gear to something particularly tricky, often quite emotive, rationing in healthcare.
Yes, a difficult subject.
The word itself makes you think of wartime, shared sacrifice. But the text criticizes how it's used now, calling it a variable, haphazard, and non-evidence-based withdrawal of access. What's the key difference between that historical idea and what's happening today?
It's a critical distinction and one that needs clear understanding. Historical rationing, say, in wartime, was usually a collective, transparent decision, often evidence-backed, allocating scarce resources fairly for the greater good. It was generally national, universal, open, with a clear why.
And now?
What we see now in modern Britain, often labeled rationing, is fundamentally different, more insidious. It truly is that variable, haphazard, non-evidence-based withdrawal of access. Meaning, whether you get your knee replacement, your hip surgery, your spinal procedure, often isn't determined by clear clinical need or national evidence, but by arbitrary non-clinical factors.
Like your postcode.
Like your postcode. Or the specific local policies of your clinical commissioning group, the CCG, the local NHS body buying the services, or arbitrary BMI thresholds that differ wildly from one area to another, or smoking status criteria that aren't consistent.
So it's not fair or consistent.
It's the difference between saying, we all agree to limit this based on clear, fair rules for everyone versus a postcode lottery, where thresholds vary without clear clinical justification or public accountability.
And it's not transparent.
Often opaque, inconsistent criteria. It fundamentally creates huge inequalities, which I believe goes against the core principles of a fair NHS.
And the text calls it an aberration, when patients avoidably losing their dexterity, mobility, and quality of life just based on where they live. That sounds, well, unacceptable.
It is unacceptable, an aberration, an ethical crisis. The idea that your address, not your need or suffering, dictates whether you lose function and quality of life. It's just wrong in a developed nation committed to equitable health care.
So what can the orthopedic community do? How can we effectively fight against these unfair disparities?
We have a huge role, a moral duty actually, on several fronts. First, data. We must keep collecting, analyzing, highlighting robust data on these variations in access and outcomes, show the evidence of inequality, expose the haphazard nature.
Use the evidence.
Precisely. Second, engagement. Proactive, collaborative, constructive engagement with commissioners, with policymakers.
Even though their expertise differs, the text calls CCGs talented generalists.
They often are, doing vital work managing broad health services with complex budgets. But their specific musculoskeletal expertise is naturally less deep than ours. That's not a criticism, just specialization.
So our role is?
Not to belittle, but to collaborate. Bring our detailed, evidence-based knowledge. Explain the real clinical consequences of access barriers, the prolonged pain, disability, loss of independence, the long-term societal and economic costs of delay or denial.
Using our trusted position.
Yes. Leverage that high public trust. Speak with a united, authoritative voice, not just for our profession, but for our patients. It's not about blame. It's about collaborating for more equitable, transparent, evidence-based care pathways. Fair access for everyone, regardless of postcode.
That leads perfectly into using that trust we talked about earlier. We know the public trusts us doctors much more than politicians.
Generally, yes. The data shows that.
So how can orthopedic surgeons really harness that trust to argue more effectively for patients, especially when our specific musculoskeletal expertise is deeper than that of the CCGs, the talented generalists?
That public trust is, as I said, powerful social capital. We have to use it strategically, ethically. When advocating, especially with CCGs, it gives our collective voice real weight.
How does that play out?
CCGs manage incredibly complex systems, budgets, population needs. They can't be experts in everything. They lack the deep, single-system knowledge an orthopedic department or specialist society has. Again, just a fact of specialization.
So we fill that gap.
Our role isn't to criticize, but to collaborate by bringing that specific, evidence-informed knowledge. We educate them on the real clinical impact of their policies, what delaying a knee replacement actually means for someone's mobility, pain, ability to work.
Highlighting the burden.
Yes, the true burden of musculoskeletal disease. The often underestimated long-term costs, societal, economic, of delaying or denying treatment, which frequently dwarf the initial saving.
Using our credibility.
Exactly. Leveraging our trusted status ensures specialist insights aren't just heard, but genuinely integrated into decisions, leading to more rational, patient-centered resource allocation. We become authoritative advocates for pathways reflecting clinical need and best practice, translating expertise into system-wide benefits.
And to do that effectively, the deep dive suggests we need to wear expertise lightly, avoid seeming like other, intimidating, unapproachable, which can put patients off.
Yes, that's crucial.
What does that humility actually look like in practice for highly skilled specialists in a technical field?
Wearing expertise lightly means consciously breaking down those perceived barriers, recognizing that while our technical skills, our knowledge are vital, our ability to connect as humans is just as, if not more, important for building real trust.
Ow.
Genuine empathy. Taking time to listen actively, not just to symptoms, but the patient's story. Using clear, jargon-free language. Acknowledging their concerns, fears, hopes.
Showing our own humanity.
Yes, sometimes where appropriate. Sharing our own human worries, fallibilities, and foibles. Maybe a brief, anonymized anecdote, acknowledging everyday challenges. The goal is bridging the gap, showing we're not some alien species despite our specialized knowledge.
Making us relatable.
It makes patients feel more comfortable, less intimidated, more open to accepting best practice plans, even if it's difficult or wasn't their first thought. It changes the consultation from top-down instruction to a collaborative discussion.
Little things count.
Definitely. A small joke, acknowledging a shared mundane frustration. If only I could stick to my diet like I'm asking you to stick to your rehab. It instantly makes you more human.
That dynamic shift is critical, and it highlights the importance of the next generation, too. The text suggests quite insightfully that more junior trainees may know patients far better than we do.
Often true.
They engage with them at their most vulnerable moments. How do we make sure those vital perspectives are actually heard and valued in our sometimes quite traditional hierarchical structures?
This is so important for a collegiate, effective, and ultimately safer environment. Junior trainees, foundation doctors, core trainees are often the first contact in emergencies, rotating through, talking to patients in the dead of night, hearing family concerns the specialist might not.
They get a different picture.
A holistic, immediate, often deeply personal understanding of the patient's context, home life, anxieties, support network. Things senior staff, maybe focused on the complex surgical plan, might miss.
So how do we capture that insight?
We have to actively dismantle overly rigid hierarchies that block communication. Create protected space in trauma meetings. For junior voices, explicitly invite their insights, value them, don't just tolerate them.
And on ward rounds?
Make ward rounds more than just note-writing exercises. Encourage juniors to present, voice concerns, challenge assumptions respectfully, contribute meaningfully to the plan.
And assessment.
Use workplace-based assessments not just for ticking boxes, but for real mentorship and dialogue. Show we're willing to concede that others, including juniors, may know more than we do about certain patient issues. It fosters development, critical thinking, and enriches our collective understanding. Better, more compassionate care follows.
And beyond the immediate patient benefit, that perpetual churn of junior posts, frustrating sometimes, maybe.
It can feel disruptive, yes.
But it's also a unique chance to educate doctors who won't specialize in orthopedics, but will interact with it forever. It's a long game, isn't it?
Absolutely. A powerful, often unrecognized long-term benefit. That constant churn of foundation and core trainees might feel like endless inductions for us. But strategically, it's an unparalleled opportunity for system-wide education. These doctors become GPs, A&E docs, geriatricians, rheumatologists.
And their ortho experience matters.
Hugely transformative. Even a short time in orthopedics empowers them later to make a confident decision, target a referral effectively, or spot the just not right with a musculoskeletal problem.
Examples?
A GP who's done ortho on call will be more confident managing a simple fracture or know exactly when to refer urgently, avoiding delays. An A&E doc familiar with presentations can streamline assessment, avoid unnecessary admissions, provide better initial care.
So it helps the whole system.
This short-term investment in educating non-specialists improves outcomes system-wide. Better recognition, triage, communication with us. It reduces the burden on our on-call teams, too. It's a virtuous cycle, strengthening the whole ecosystem, improving the patient journey.
That's a great point about the wider benefits. Okay, let's focus now on the specific, intense world of trauma care.
Right, a very different environment.
Trauma often hits suddenly. It's profoundly disempowering for patients, pain, long waits, terrifying loss of control. How does that context, that immediate distress, shape how we should approach trauma care, especially our communication?
Trauma is unique, hugely challenging for everyone involved. Patients meet us unexpectedly, often through violent life-altering events, falls, accidents, injuries. None. As the text says, trauma respects neither pre-existing plans nor patient resource. That suddenness, the pain, the uncertain waits in busy A&Es for beds or theater, the total loss of control over their body and future, it's terrifyingly disempowering.
So our approach needs to reflect that.
Fundamentally. Recognize they're not just a broken bone. They're in psychological distress, anxious, vulnerable, often scared for their future.
Communication needs to be different.
Hyper-empathetic, crystal clear, concise, focused on restoring any sense of control possible. Even small things, clear info about what's next, acknowledging their pain, offering small choices where possible can make a huge difference when they feel utterly helpless. We're treating a person in crisis, not just an injury.
Focusing on the person is key, especially then. Now, we've seen big strides in the big surgical decisions in major trauma networks, UK trials gaining renown.
Yes, definitely improving coordination and evidence base.
Yet, the deep dive stresses it's often the little decisions, the details that patients notice most, remember most. Can you give some examples of these little things that actually have a huge impact on their experience, their trust?
This is so critical and easily missed in the rush. While the big decisions, which surgeon, which hospital are better managed now, the patient's lived experience is often shaped by those seemingly little things.
Like what?
Like, will my operation really happen tomorrow morning? If maybe not, can you tell me early so I can at least eat tonight? The stress of fasting all day, only to be canceled late, is immense, disheartening.
That resonates.
Or clarity around the post-op plan. Can this elderly person living alone genuinely manage at home with a frame, or will non-weight-bearing mean weeks more in hospital? For them, that's huge. Maybe needing family to travel versus getting back to independent living.
Practical things matter.
Or even just helping them charge their phone to contact worried family. These small details show we're considering their personal situation, their dignity. It's not just about the technical outcome. It's quality of life, human dignity, the real impact of our decisions on their whole world.
Those examples really hit home. I think we've all seen that disappointment when surgery gets canceled after fasting.
It's awful for the patient.
The text stresses we can't always guarantee it won't happen, but we can certainly warn patients early and explicitly that it may happen. How vital is that transparency, even with bad news, for keeping that trust rating high, building resilience?
Absolutely critical. Transparent communication, especially when things are uncertain or difficult, is key to maintaining, even strengthening, trust.
How so?
When surgery is canceled, the patient feels awful. Physical discomfort, emotional distress, anxiety about delay. We can't always prevent cancellations. Emergencies happen, beds are short, theaters run over, system realities.
But we can control the communication.
Exactly. Being able to warn patients early and explicitly that it may happen, preparing them for the possibility, transforms a potentially trust-destroying event into a chance to show honesty, empathy, respect.
Managing expectations.
Proactively.
Yeah.
It lets them prepare psychologically, avoids that awful feeling of being blindsided, forgotten. Being upfront, even with bad news, validates their experience, acknowledges their anxiety, shows we value their time, their well-being, their trust.
So it reinforces trust, paradoxically.
It reinforces the perception of us as caring, honest, reliable. In tough moments, trust isn't just maintained, it's actively deepened. It builds a more resilient relationship based on truth and respect, treating the patient as a whole person, not just a case on a list.
Respect for the whole person, it really is the thread running through all this.
Okay, let's zoom out now, beyond the clinic walls to the wider digital world.
Right, the online sphere.
Patients live in this information-rich world. Information gets bundled and sent to them based on their searches, their interests, their online behavior. How does that change our role? Engaging not just one-to-one, but maybe on a population level. influencing public understanding.
It fundamentally changes the game. Historically, we focused on individual engagement, the consultation, a leaflet, maybe a support group link.
The traditional model.
But now patients are digitally savvy. They navigate a personalized online world. They expect relevant, curated info pushed to them like social media feeds, news alerts, shopping suggestions.
So our role expands. It has to extend beyond the individual encounter to what's been called a new game of population-level influence. We need to think a bit like, well, positive influencers.
How do you mean?
Understanding prevailing opinions in online communities, identifying common myths or misconceptions, then strategically targeting those groups with accurate, evidence-based messages that actually resonate. Trying to gently reshape the opinion of that group towards sound musculoskeletal health understanding.
So not necessarily becoming famous online.
No, not at all. It's about strategically getting reliable information out there to broad audiences, actively tackling myths, guiding public discussion towards accurate understanding of conditions, treatments, prevention. It needs new skills, digital communication, platform understanding, recognizing our influence is now both personal and public.
Which brings us straight to social media itself. Those platforms, the 140 typed characters culture, maybe a bit more now.
Okay.
They present a huge challenge, but also an amazing opportunity for orthopedics. How can surgeons contribute responsibly to that noisy digital space, especially with misinformation spreading so fast?
Social media is definitely that double-edged sword. Its speed and reach are its power and its danger. The short-form culture can easily oversimplify complex issues, promote nonsense cures, amplify uninformed voices. That's the huge challenge.
But the opportunity.
It's an amazing opportunity for credible, responsible voices in orthopedics to push back. Specialist societies, royal colleges, journals can use these platforms strategically for authoritative info.
And individual surgeons.
Crucially, that institutional presence gets amplified by the responsible voices of surgeons and other team members, engaging thoughtfully, sharing evidence clearly, politely correcting myths, joining public conversations about ortho health.
Representing best practice online.
Yes, showing the evidence behind it, potentially reaching millions who'd never enter a clinic. This digital outreach offers that small smoothing of inequality of access, providing reliable info to people otherwise reliant on dubious online sources. It's about being present, authentic, offering a credible counter-narrative in a noisy space.
That's a powerful vision for digital engagement, a real evolution. Now, regulatory guidance on social media use is important, salient.
Absolutely necessary.
But the worry is it might stifle the discourse, make clinicians too cautious to engage properly. How can we use these platforms for open, authentic conversations that actually connect with patients, address their real questions, moving beyond just rules to genuine connection?
Regulatory guidance is vital for professional standards, patient safety. But yes, it's often formal, cautious, prescriptive by nature, designed to set boundaries, mitigate risk, which can sometimes unintentionally stifle more informal but vital conversations.
So how do we go beyond that?
On digital platforms, we have a chance to foster truly authentic dialogue, build bridges, adopt a more conversational human tone, address common anxieties directly, answer FAQs accessibly without jargon, share insights reflecting patients' lived experiences, not just clinical data.
Showing we get them.
Exactly. Showing that we understand them, not just their condition, but their worries, hopes, daily challenges, how it impacts their whole life. Authentic engagement bridges that gap between abstract medical knowledge and real-world concerns. It reaches beyond the clinic.
Humanizing the profession online.
Yes, showing our care and expertise relatably, connecting with a broader public, building a more informed, empowered, trusting community around orthopedic health. Using digital's power to educate, reassure, engage in ways formal channels alone can't. Hashtag tag outro.
Wow, what a journey through the layers of orthopedic practice in this really quite complex modern world.
It certainly is complex.
We've really dug into how we as orthopedic professionals can stay trusted experts. By embracing evidence rigorously, fostering genuine collaboration, prioritizing every single bit of the patient experience from outpatients to the tiny details in trauma, and, crucially, adapting to these new ways of communicating. It seems so clear that transparency, high communication standards, and that unwavering commitment to evidence generating it, synthesizing it, are absolutely fundamental, the bedrock principles.
Couldn't agree more. And I just add, our collective responsibility as the orthopedic community is to keep championing effective interventions, properly evaluating what works, and getting that message out with, well, articulate confidence.
Confidence, yes.
In this dynamic world, holding on to that trust means being scientifically robust and authentically human. And actually, that articulate confidence, maybe using social media thoughtfully, could be a hugely powerful tool to drive that message home, reinforcing trust with a much wider audience.
So, as we wrap up, perhaps a final thought for everyone listening. What does it truly mean for you to wear your expertise lightly? To be both that rock-solid expert and a relatable human in an age where information is everywhere but trust. Trust is earned in new and profoundly personal ways. If you found this deep dive valuable, please do consider rating and sharing it with your colleagues. Thank you so much for joining us on Deep Dive Ortho.
Thank you.
We'll be back soon with more insights.